will not be alive in the box. It's a case presentation, but thank you very much for the invitation. Good morning from me. And we have seen today very nice TEER reports, cases. I'm showing you another mitral intervention. We have a 78-year-old patient with recurrent cardiac decompensations. She has a dyspnea from third class. Her BNP is over 3,000. She underwent in 2021 cardiac surgery with the aortic replacement and a mitral valve replacement, trifecta 19 and EPIC 27. She also has a pacemaker due to AV block 3, has atrial fibrillation, hypertension, diabetes. In the coronary angiogram, it showed no cut, and this is her TTE. We see that the mitral valve is severe degenerative valve. We have a mean gradient from 14.2 millimeter mercury, showing a severe mitral valve stenosis. And we also have a margin, a central one, and also a small eccentric one in the area from. I will show you in the one area, in the one segment. According to her age and the other comorbidities, we decided that we should go to a transcatheter mitral valve intervention and not to operate again, because it was 4 years ago her cardiac surgery. We did firstly a CT so that we can measure exactly the mitral valve. We can see that we have a distance between the aortic annulus from 24.3. The distance inside the valve is 22.8 millimeters. The distance from the LVOT, that's also very important to know, because the new mitral valve will be inside the old one, and we can have an LVOT obstruction, was 10.3, and the average mitral valve annulus area is 4.7 square centimeters. According to all the measurements, we decided, or the perfect sizing was a Resilia, 26 millimeters. And so we started with, of course, the patient is intubated, and we went for the right femoral vein under echo guidance, and we put the pacemaker lead from the left vein. So we'll go you through the intervention. As we see the screening TOE before we start everything, it confirms that the valve is degenerative, has alterations, and we can see here a minor, I don't know if the if it shows it very well, the minor flail, that is the eccentric component from the MR. So we go as a TEER procedure. We do the transeptal punction under echo guidance and angiogram, and we place we place everything in the pulmonary vein. We go then afterwards with our safari wire in the through the mitral valve in the left ventricle, and in the first we are going to inflate the old valve with an Atlas balloon, 26 x 14 millimeters, before we then place the new valve, the Resilia 26 millimeters. We see the position through the angiogram and also through the TOE echo. Then after all the measurements, we are happy, and then we start to inflate the new valve under, of course, rapid pacing. Afterwards, we did a post dilation in order to give a shape better shape to the new valve so that it can take all the measurements at the higher mitral valve annulus area that it can. And we have this and with a perfect position for the mitral valve, no paravalvular leak, no MR no transvalvular MR with a 3.8 millimeter mercury mean gradient. That is the remaining shunt in after the transeptal puncture with a left-right shunt, and this is the TTE afterwards, before release. We see perfect positioning from the valve without any MR, and the gradient was 2.2. Patient's going well and is asymptomatic in the moment. Thank you very much.
Great. Ideal treatment for this kind of problem.
Right.
Yeah, and easy hemostasis. Very good.
It was good. It's just, I don't know, so some small technical tips we used always. Two safaris, I don't know, in your practice, if you do that, Akis.
Two safaris?
For as a body wire, the
body wire.
just to facilitate the easiness.
Did you do a septostomy with the balloon?
Yes,
you
yes.
did, and then you used
12
two safaris.
of 14, and then we do the septostomy, and then we use two safaris to advance the valve, and then we take out the other one.
So
So-
yeah,
yeah.
okay, it worked two ways. Sorry, if it wasn't.
Backup, but I think if you do a good septostomy, like the good Rashkin maneuver, it normally works with one. But it's a good a body wire, a good idea to in terms of having more backup. It's smart.
Yeah, you see how the curve is when you know, if it's a kind of, and also you get a sense during the ballooning, if you start having a little problem with a deflated balloon, I used to go a few times back and forth just to see how it works.
Exactly.
If it kind of catches even a little bit, then there could be a problem. But most of the time, as you say, it doesn't catch and it goes smoothly and all that. Well, that's great. Thank you very much. And let's move on to immediately to the